So thank you, Alfredo, for this nice presentation on the retrograde approach. My task is to go through the antegrade approach now, step-by-step instruction. And to start with, I think each CTO, when we do a lot of them, when we look to a lot of them, has its own heterogeneity. Of course, if you look to the pathological heterogeneity, is very low in short occlusions, as in this case. But when you look to longer occlusions, they are more pathologically complex to get through an antegrade approach. This is why a high level of heterogeneity with a long occlusion often predicts the need of alternative strategies, and Alfredo mentioned the retrograde approach as an alternative strategy. So this is reflected in a decreasing effectiveness of antegrade wire escalation with more complex anatomy. This is why you need to understand your anatomy, you need to use the score, and as you can see here, when you have a Japanese CTO score 0 to 1, your success rate could be up to 90% using an antegrade wire escalation. However, when your Japanese CTO score will go up to 3 or higher, then only antegrade wire escalation will not bring you to a high level of success. You need to use alternative strategies such as the antegrade dissection reentry or the retrograde. This is why, again, the careful angiographical analysis, sometimes using endovascular imaging or a coronary CT scan, can help you to assess and to determine if the antegrade wire escalation strategy will be a successful one. And again, you will see this algorithm a lot of times during my presentation and during the cases I will show you. Dual injection, look to the cap, look to the distal target, look to the interventional collaterals, and look to the strategy and the lesion lengths to see if you go antegrade wiring, or you go antegrade dissection reentry. So how do you proceed? You bring your workhorse wire, you bring your microcatheter at the proximal cap, and then you need to palpate. You need to see if you have a probability of penetration to that proximal cap and to navigate if there is any microchannels. And we know from pathological studies that microchannels, even if we don't see them angiographically, it doesn't mean that they doesn't exist. So in this old series of pathological data, complete full CTO without any microchannel within the occluded segment is only in a quarter of patients. The majority of patients may have microchannels. However, the anatomical pathway of those channels could be highly complex to navigate through. So when you have a proximal cap, you need to palpate, you need to see if you will be able to penetrate and to progress within a pre-existing space or to make that space. So when you have a tapered cap, we usually start with the Fielder XT. As I mentioned, you can switch to the Gaia family wires. When you have a blunt or proximal cap, you need to use, or calcified cap, you need to use a piercer such as the Confianza or the Hornet wire. And as soon as you pass through that proximal cap, you need to de-escalate, and then you go back to the Fielder, you go back to the Gaia segment that we usually use, and when you are again going to the distal cap, and if this distal cap is again fibrotic and calcified, you can re-escalate again and use piercer's wires to go through that cap. So tapered proximal cap, microchannel exists. XT wires are the wires that we use. The XT or the Fighter from Boston also is a good alternative. So this is here a case of a dual injection proximal LAD. You see some tapering on the proximal part, and microcatheter that we brought was on a workhorse to the proximal cap, and this is a Fielder XT. It's a 30 seconds wire, it's a 60 seconds wire. If within 1 minute of manipulation, you are not able to cross with the Fielder, stop, don't persist, don't be persistent to continue turning around with that wire. And you can see in 20 seconds that Fielder XT find a microchannel that we were not able to see angiographically and get down to the vessel. You go down with your microcatheter, you remove the Fielder, you put a workhorse trapping technique, you take the microcatheter out, you pre-dilate, you put one stent, and this is the final result. Tapered proximal cap with increased marker of complexity, and if you stick that cap and you have a complex body of the CTO, then you need to escalate with the wire. So this is a case that were brought to us after a previous attempt, and you can see the multiple dissection plans within that occlusion of the CTO that was previously attempted and ended up by having a lot of dissection plans. So again, this is a left Amplatz one microcatheter with a workhorse to the proximal part, and we were able to navigate through that dissection and get to the proximal, get to the distal part of the. I'm trying just to play the. Anyways, we were able to proceed and to get distal to the distal part, distal cap of the CTO with a Gaia segment. However, we were subintimal. We were able to redirect it and go to the true lumen. However, we were unable to advance the microcatheter through the distal cap. So what we did, we pre-dilated up, and as you saw, we had a very fibrotic and calcified plaque in the proximal part of the RCA, not on the distal part. So we were able to broad the turnpike at the distal cap of the CTO. The turnpike wouldn't be able to go to the distal part of the right coronary artery. We wedged the turnpike there, take out the Gaia and advanced a rota wire. And then we were able to perform a rota in that proximal admit part of the RCA. And after we had to go up with 30 atmospheres on the proximal stenosis to open it up. And this is a wiggle wire in the artery, and we were able to put 2 stents to succeed opening that artery. If you have a blunt stump, you have a calcified proximal cap or highly fibrotic, then you need to use a piercers. And as we said, the Hornet 14 or the Confianza are good wires to stick. So here you can see a stent that was implanted in 2006, and very ambiguous cap. You have a takeoff of a side branch, just a big side branch, just close to the proximal cap of this instant occlusion. So we started using a Confianza Pro, and as you can see on the right panel, you can see that the Confianzas are going aside the stent. It's not sticking within the lumen of the stent. So we were able to redirect after sticking within the lumen of the stent, and this is something that you need to verify in 2 orthogonal views to be sure that you are not passing aside to the stent, that you will crush it or you will manipulate. So we stick with the Confianza. We were able to advance the Confianza in the middle part of that stent. Then getting there, you need to descalate. You don't continue with the Confianza. We were able to switch to the Gaia segment. The Gaia segment did progress out from the distal cap, however, remained subintimal as you can see. So we started to have a hematoma in the distal part of the RCA. So we said maybe it's time to do not insist and propagate that hematoma, and we need to switch to an alternative approach. So we went retrograde. Here it's a distal tip injection, and we don't see any connections from that septal we injected to the RCA. We were able to find another connections. However, that connections, as you saw, brought us very close to the distal part of the distal cap of the CTO, and we are not in the lumen of the PDA. So it's not a good connection. If we take these connections, we will exclude the distal target of the vessel. So we postponed and we aborted the retrograde approach, and we came back again to the antegrade approach. And now we try to do a last technique using the Gaia third. And as you can see here, the Gaia third were able to refine the true lumen and to gain the true lumen of that PDA, and the stenting from the distal part of the right coronary artery to the mid part was a 2 drug eluted stent, and this is the final result. So it's a movable target, as I show you, starting with penetrating wires, Confianza, switching to Gaia, failure, retrograde, failure, come back, antegrade, and being able to use a last technique with the Gaia third wire and regain the true lumen. The most common reasons of failure using the antegrade wire escalation is the use of only one guiding catheter, excessive antegrade injections. So when you start having subintimal materials, you need to stop injecting with your antegrade system, and you only inject through the retrograde to see where you are getting distally with your wires. Wrong wire strategy, no usage of microcatheters, wrong guiding catheter support, misunderstanding the probability of success if you perform ad hoc PCI, and of course, misunderstanding of the algorithm. So if you do not succeed to get an antegrade wire escalation that will bring you to the true lumens, that you need to switch for a dissection re-entry strategy. There is a lot of those strategies. There is the old STAR technique, the contrast guided STAR technique that was described by Carlino, and there is the mini STAR using small knuckles for a short distance, and the last, which is the limited antegrade subintimal tracking. This is a wire-based re-entry that we use dedicated wires such as the Pilot, the Gaia second or third, or the Confianza to re-enter using a double shape on the distal tip of the wire. And of course, you have the re-entry system, which is the Crossbus and the Stingray system that you can use. So here you have a distal right coronary artery occlusion. As you can see, this occlusion is very distal. So again, we go with a microcatheter at the proximal part using a workhorse, and then we navigated using a Gaia second. The Gaia second is close now to the distal tap, however, it's still tracking in the subintimal space. Pilot 200 was able to gain using a last technique to the PDA. However, you see that the re-entry point is just distal to the takeoff of the continuation of the RCA, and you don't want to lose this major branch. So what we was able to bring is to go down with a twin pass, position the twin pass at the takeoff of that continuation, and to stick with a Pilot 200 to regain the true lumen. And this is the final results after stenting from the continuation of the RCA to the distal part of the RCA. So the antegrade dissection and re-entry, the dedicated system is using the Crossbus catheter, Stingray balloon, and the Stingray wire. Of course, in the Progress CTO registry, the usage of antegrade dissection and re-entry was mainly used for long CTOs and higher Japanese CTO scores, 3 or more. And of course, when you use the ADR, you have a less technical and procedural success rate. So this is one of the first cases that we performed using the Crossbus and Stingray. It was in young patients. That patient that was waiting for a lung transplantation due to idiopathic fibrotic pulmonary disease. He have angina. He have a significant ischemia in the inferior territory. And the transplant team said, if you do not fix this ischemia on this patient, we cannot list him for a lung transplantation. So this is right coronary artery occlusion that was attempted both antegrade and retrograde and failed in both cases. So looking to the algorithm again, long lesions, previous failures, good distal target. We decided to go using the antegrade dissection and re-entry. This is a microcatheter. The wire was going in a subintimal space, so we kept the position of that wire, remove the microcatheter, and go down with the Crossbus. The Crossbus was tracking in a subintimal space. We advanced the Crossbus to the horizontal segment of the RCA, where you have most probably a higher success rate to regain the lumen of the distal RCA. So you put a workhorse there in the subintimal space. You take out your Crossbus and you bring the Stingray balloon and you try to restick using the Stingray wires. You inflate that balloon with up to 4 atmospheres. You verify in 2 orthogonal view, and you use the proximal pore of that balloon to try to restick toward the lumen and not the epicardial space with the Stingray wire. After you stick with the Stingray wire, you can switch to a Pilot 200, and we were able to gain the true lumen of the posterolateral branch, stenting from the distal part to the proximal part of the RCA. This is the final results. Still following these patients. The patient get a lung transplant and he's free from angina. This is another case of LAD CTO, proximal LAD CTO, quite ambiguous part, big septal branch, not too long CTO. So what we did, we went antegrade. The Gaia second were going sub-antimally, and we didn't want to push further to re-enter as LAD has some disease after the takeoff of the second diagonal. So we kept the position of the Gaia, advanced the microcatheter, take the Gaia out, put a workhorse there, and we were able to advance the Stingray system. Here you can see the inflation of the Stingrays with the contrast of in the balloons. And using the Stingray wire, we were able to advance the Stingray wire and switch it to a Pilot 200, then a workhorse wire in the distal part. This is another view of the Stingray wire. And this is the stick and swap going to the true lumen through the proximal pore of the Stingray balloon. The Pilot 200 gain the true lumen distally, switch to a workhorse, proximal stenting of the RCA, and this is the final results. So in conclusion, the antegrade remains the most common approach. Advanced techniques allow you a higher success rate, either using the antegrade wire escalation or the antegrade dissection re-entry. And of course, the retrograde will remain also an alternative when you fail using this technique. You can switch to the retrograde, and you need, as Alfredo said, you need to gain some experience in the retrograde to switch from one approach to another one. Thank you very much for your attention.